want to welcome everybody to today's topic, Scoping the Scene, Coding Bronchoscopies in ICD-10-PCS. And Christy is a senior consultant with Haugen Consulting Group. She's got more than 20 years of industry experience. She is responsible for the development of our web-based and instructor-led training materials, as well as conducting training in ICD-10-CM, PCS, and CPT. She also performs DRG and APC audits as well. Christy's a Colorado native who has never skied. In her spare time, she partakes in outdoors activities that do not involve strapping two boards to her feet and barreling down a slippery slope. She also enjoys mentoring new coders and spending lots of time with her family. So Christy, at this time, I think I'm going to turn it over to you.
Thank you, Kathy, and just wanted to echo what she said about thank you for joining us today for the webinar on coding bronchoscopies in ICD-10-PCS. On our agenda today, we're going to be talking a little bit about respiratory anatomy only as it relates to the body part values that are in PCS. And we're going to talk about some common procedures that are performed through a bronchoscope. But as I was creating this presentation, realized that there's a lot of opportunity to do additional webinars on interventional pulmonology. So if that's something that you're interested in, if you want to just, put that in the comment on your evaluation, that would get into VATS and some of the other not super invasive pulmonary procedures that are not done through a bronchoscope. And then we will also discuss the appropriate body part for bronchoalveolar lavage and transbronchial biopsy. And today, in case you're wondering where the wolf and the three pigs came from, we were trying to think of something that kind of went along with the whole lungs and breathing topic, and this just jumped into my brain. So we've got the wolf and the three pigs today, which I thought were kind of cute. We also have lots of anatomy pictures. As we do in a lot of our webinars, we wanted to include as much anatomy information as possible. And when you first look at the PCS body parts under the respiratory system, body system in PCS, there are a whole lot. And on this slide, I'm just showing you the body parts that are related to the trachea and the bronchi. And the biggest thing to point out here is that when it comes to the bronchi, we have different body parts for the right and left main bronchus, as well as each individual bronchial lobe. And this is just the bronchi. If you look at the anatomy here, you see we've got the trachea, trying to get my laser pointer going, the trachea, the windpipe, which is dividing into the main bronchi, and then the lobes of the lung, where the bronchi enter the lung, then you have different lobes as well. One of the body parts that is available for PCS is the carina or carina, which is that cartilaginous ridge at the base of the trachea where it branches into the right and the left main bronchi. And every once in a while you'll see some procedures that are performed at this location. It's not something we code a lot of, I don't think, but there is a separate body part specifically for that. When we get into the lungs, so now we're not just talking about the bronchial tree here, we're talking about the actual lung lobes, then we also have PCS body parts for the individual lung lobes. It's important that you read the body part descriptions very carefully, because you'll have an upper lung lobe right, but you'll also have upper bronchial lobe right. And just a quick note about the fact that you have three lobes on the right side, the right upper, right middle, right lower. On the left side, you only have two, the left upper and the left lower. But there is a little piece of tissue or tongue-shaped area called the lingula. So that's why it's called lingula. Lingula means lung. That is where the left middle lobe would be if it existed. But because of the location of the heart, you don't have a left middle lung lobe. When it comes to guidelines and body parts, I wanted to take a moment to point this out. And I always like to go back to guidelines when possible, because I think we have a tendency to forget about some of these. But there is a guideline about bilateral body part values that says that there are bilateral body part values for a lot of the body parts in PCS, but not for all of them. And if you have a procedure that was performed bilaterally and there is not a bilateral body part value, that you need to assign a code for each side, for right and left. And you will see that throughout the bronchoscopy coding session, that if they did something in the right upper lung lobe and the left upper lung lobe, there is no bilateral upper lobe. So you're going to have to assign 2 separate codes. Additional body parts that we need to be aware of. This one is actually outside of the respiratory system and in the lymphatic tissue body system, where we often see procedures that are performed on the lymphatics. And there are various different types of lymph nodes that are located close to the lungs, and by placing a scope into the respiratory system and puncturing outside of the lung and into the adjacent lymph nodes, we're able to sample that tissue. So anytime you see that they are doing a biopsy or procedure on the lymph nodes through a bronchoscope, then the body part for that is going to be the lymphatic thorax, or the 7 PCS body part value. Other guidelines we want to pay attention to. The multiple procedure guideline is used a lot in coding for bronchoscopy procedures. And during this, or for the examples that I am showing on the screen, we have the guidelines, which are shown in colors. This is a multiple part guideline. So it's guideline B3.2a, B3.2b. And in the guidelines, they give lots of examples. So the guideline is verbatim, but I changed the examples here to be specific to the bronchoscopy setting. So in the multiple procedure guideline, it says during the same operative episode, multiple procedures are coded if the same root operation is performed on different body parts as defined by distinct values of the body part character. And the example we have here is biopsy of the left upper lobe bronchus and the thoracic lymph nodes. The next guideline, you code multiple procedures if the same root operation is repeated in multiple body parts, and those body parts are separate and distinct body parts classified to a single PCS body part value. Now, when I read that, it sounds very similar to the first part of the guideline, but the example that I've given here is a transbronchial biopsy of the right upper and middle lobes. And I know I didn't say of what here, let's just say it's lung. But if they did a transbronchial biopsy is lung. They did a biopsy of 2 lung lobes, but they happen to be 2 separate lung lobes. They have different body part characters, therefore they get separate codes. We also code multiple procedures if there are multiple root operations with distinct objectives performed on the same body part. The example here is a bronchial biopsy of the left lower lobe with bronchoalveolar lavage. And in a bronchoalveolar lavage, we're taking fluid out, whereas in a biopsy, we're taking tissue out. So those are 2 different root operations with distinct objectives. And then finally, we code multiple procedures if the intended root operation is attempted using one approach, but has to be converted to a different approach. Now this one, I was hard pressed to find an example for, and tapped into one of our CDI professionals on the team, and I said, you know, when would we ever see this? And he's like, you know, it's still kind of far-fetched, but it's possible that you could have a transbronchial biopsy that couldn't be completed because the lesion was very peripheral, and so they had to convert it to a video-assisted thoracoscopic surgery or a VATS. And that might be a situation where you would have multiple procedures, but pretty unlikely for the most part. I don't want to say impossible, because then tomorrow somebody's going to send me a chart where they do something like that. So let's start with the very basic type of exam. That's a diagnostic bronchoscopy. And in a diagnostic bronchoscopy, I think most of the time when we see this, either they had to discontinue the procedure for some reason, or they just didn't find anything as they went in and they decided not to do biopsies or whatever else. But remember that when we have a diagnostic procedure where there's nothing definitive done, no tissues taken, and there's basically nothing else to code, the root operation is inspection. And so I've shown you the inspection table here. There is an important guideline that goes along with this. If multiple tubular body parts are inspected, the most distal body part, or the body part furthest from the starting point of the inspection, is coded. And if multiple non-tubular body parts in a region are inspected, the body part that specifies the entire area inspected is coded. In the respiratory system with bronchoscopy, the scope is being advanced through the mouth or sometimes through the nose, down through the trachea and into the bronchial tree. A lot of times you'll see physicians saying that he did a tracheal bronchoscopy, where you're like, oh, I need to code the trachea and the bronchoscopy. But in that situation, applying this guideline, which is an exception to the multiple procedure guideline on the previous slide, we would only code this as inspection of what would be basically the bronchi, except that we do have that big body part for tracheobronchial tree. So it's really kind of looking at all the guidelines together and applying multiple guidelines, including the multiple procedure guideline, to a single procedure. And this is going to bring us to the first polling question. Kathy, would you open up the polls for us, please? Okay. And I saw that somebody said they couldn't hear Kathy on that one. So just if you guys could give us a quick chat and let us know if you were able to hear her or not. The question, the answer to this one is true. This is going to apply both that bilateral coding guideline as well as the guideline for multiple procedures. When you have biopsy performed on the right and upper lobe bronchus and left upper lobe bronchus, then you are going to have both codes. With, I don't know, maybe this question was a little bit too easy, and if you felt like it was, then it'll get a little tougher here in a minute, I promise. Okay, I'm seeing some things come through the chat window that people were not able to hear Kathy. So we will work on that for the next polling question. Let's talk about discontinued or incomplete procedures, because I think a lot of times in the inpatient setting we may see this where they start to do a procedure through a bronchoscope and then for some reason they have to discontinue it, or it is considered an incomplete procedure. So remember that if the intended procedure is discontinued or not completed, and there's not a root operation that fits the procedure that was done, meaning there seemingly is nothing to code, then you would assign the code for inspection, or the root operation inspection. When it comes to placement of fiducial markers, this is, there was a coding clinic question posed about this back in first quarter of 2014. And just a quick reminder that there was a guideline, there is a guideline, B6.1b, that says specifically that radiological markers are not considered to be devices, and it's not something that is coded. And the intent of placing a fiducial marker is to insert a radiographically visible marker. It can be gold or a dye in or near a tumor. And the patient is then either transferred immediately or potentially comes back at a later time to have that tumor removed. And this is reported with the root operation inspection when nothing else is done. So if all they did was bring the patient in for a fiducial marker placement and they did no other procedure, then it codes to inspection. With another biopsy or another procedure, so maybe they did a biopsy and they placed the marker at the same time, then you don't code the fiducial marker at all. And here's a fun fact in case you're wondering where the word comes from. Fiducial comes from the Latin word trustworthy, and that means that it's called that because the marker can be relied upon to faithfully indicate the location of a tumor in order to aim the radiation therapy or doing whatever other procedures they want to do. So kind of a cool fun fact for grammar geeks like me. Let's talk about biopsy. Biopsy is not super simple. When we say we're going to do a biopsy, there can be several different terms or several different root operations that we're working with. So first of all, the 3 root operations we'll be dealing with that have to do with biopsy or cytological analysis are excision, extraction, and drainage. And remember that excision involves cutting out cutting out part of a body part, which would include all of our biopsies. Extraction is removal by force, which sounds, I always thought that definition sounded very traumatic and dramatic, but when we look at some of the brushings and the other types of biopsies that are available, you can kind of see why it's not coding as an excision. And then finally, drainage, which would involve removing liquid. The body parts are going to be different. It can either be the bronchus, or if they document it as transbronchial, then it's coded as lung. And the image that you see here is showing a blown up picture of the distal end of this bronchus, and at the end we've got what looks like little grapes at the end. Those are the lung alveoli. And when they do a transbronchial biopsy, they are going outside of the bronchi and they're sampling extra tissue, which then codes to lung rather than bronchial or bronchi. And these alveoli, remember these because we're going to come back to that in a minute when we talk about washings and how those are treated or sampled. A quick reminder, this is one of my favorite guidelines in PCS because it's always kind of been my soapbox that coders are not dumb, and we know quite a bit. I mean, you don't read medical records every day without picking up a couple of clinical tips. And the guideline A11 basically says that we don't need the physicians to use the same terminology. It's our responsibility as coders to understand how the procedures are being performed and translate the physician's documentation in the operative report into the codes and the root operations. We'll never see a physician, I don't think, using the word extirpation in his documentation. As a matter of fact, I should say that last week we did a similar presentation for CPT. So if you happen to miss that, Shay did a great presentation last week. And you don't have to know what extirpation means for CPT. And we were kind of comparing some things, and she's like, well, what is extirpation? Because she doesn't code PCS. So doctors don't have to use our terminology. We just have to be able to translate it and move it over. Let's start, well, we started with introducing the broad concept of biopsy, but let's talk specifically about the different types of biopsy, and starting with what I think is the simplest form, but a clinician might disagree with me. We have bronchial washing and bronchoalveolar lavage. And the first thing I want to throw out there is beware of the terminology, because they're not the same thing. A bronchial washing is not anywhere close, well, it's kind of close. It's not the same as a bronchoalveolar lavage. So bronchial washing, your body part is going to be the bronchi, and then, you know, whether it be the main left or right, or the upper, middle, lower, etc. A bronchoalveolar lavage, or BAL, is really sampling liquids from, or secretions from the inside of the alveoli. And the alveoli are, like I said earlier, part of the lung. So when they do a bronchoalveolar lavage or BAL, the body part is the lung. How this is performed is they take solution and they flush it through either the bronchi or the alveoli to collect cells, and then they suck that fluid back out and send that for cytological analysis. What makes these very different, and some things that kind of give you an idea that these are different, is bronchial washings are very low volume. This is bronchi as opposed to the lung, and they don't do any wedging of the catheter, so they don't wedge that catheter into the bronchi. And bronchoalveolar lavage is usually a higher volume of saline, and in order to accomplish that, they wedge the scope into the distal bronchus here so that they can get a sample of the cells inside the alveoli. And if you kind of think of it as the solution is going where the surgical instruments cannot, we can't get a biopsy all the way back in these alveoli because we can't fit biopsy forceps all the way back there, but we can get the solution, kind of shoot it into the alveoli and then suck it back out and send those cells off for cytology. Both the bronchial washing and the bronchoalveolar lavage are going to code to the root operation drainage. And it might be tempting to use the root operation irrigation if you are not looking at the index in ICD-10, but if you are looking at the index, it does lead you appropriately. It'll say, for lavage, it says C, irrigation. But then for bronchial alveolar, it sends you to this drainage root operation. Your body part could be pretty much any of these. Just remember, bronchial washing codes to bronchus, whereas the BAL codes to lung. Your approach for all of these is going to be via natural or artificial opening endoscopic, because the scope is going down the patient's throat or through the nose and down the throat. And then your qualifier for these is always going to be diagnostic. This is a form of biopsy or cytology where we're trying to diagnose something. Extraction, and this one makes me laugh because this is what a bronchial brush looks like, but this is not a bronchial brush. This is a picture of a brush that's used to clean straws. So if you have children and sippy cups, you're probably aware of this. I showed this to a clinical colleague, and he said, you know, it really does, it's very convincing. So that's kind of what they look like. To me, it looks like a kind of a mascara brush. When they do brushings, they advance this tiny brush like this, and it's kind of a swab that they do inside of the bronchi to collect some of the cells. And this codes as extraction. We're actually getting some cells, but we're not cutting anything out. And this is one of the newer tables. We did not have this when ICD-10-PCS first came out. And again, you'll notice the only qualifier on this is diagnostic, because this is only done for diagnostic purposes. And then biopsy. And the picture shown on this slide is a picture of biopsy forceps that are used to actually grip and cut out tissue. And you'll see how that's very different from using the brushings and doing the washings as well. Just make sure you're watching your terminology here, because bronchial biopsy, remember the body part is bronchus, but if they say transbronchial, then the body part is going to be lung. And both of these code to the excision table. Each body part will be coded separately if applicable. If they did multiple lung lobes or multiple bronchial lobes, then you're going to have a code for each individual lobe. Your qualifier for biopsy is always going to be diagnostic. And again, these are, remember that they often will, or they usually will send whatever they remove during a procedure to pathology. But what makes this diagnostic from a qualifier perspective is that the only reason for removing that tissue is to get that pathological diagnosis. If they removed a lesion and they also happen to send it off, then it's coded as no qualifier. But if they were really trying to get that diagnosis and get that pathology back, then the qualifier is diagnostic. So I've got a biopsy case example, and wanted to give a quick shout out to mtsamples.com, which is a medical transcription website where they have lots of different procedure reports, and we use some of their reports for this presentation. And this procedure starts out, I've included the entire procedure here in case you're like me and you want to see the whole thing, but I'm not going to read the whole thing. I've just highlighted a couple of things that I found interesting. In the procedure header, even though we need to still read the report, we can never code from procedure headers. The things that jumped out at me here were the fact that he talks about doing a flexible fiber optic bronchoscopy. And I will tell you right now that the flexible versus rigid is a big deal for CPT coding, but it makes no difference on the PCS side. It just has to do with rigid scopes are exactly what they sound like. It's a piece of metal or a rigid tube that gets stuck down, and you can only go so far with that. Fiber optic is just like you're thinking of with, you know, fiber optic cables that we have in so much of technology these days. It's very flexible, it can bend, it can go around corners, and we can see more with a flexible bronchoscopy. But again, not something we need to know for PCS coding, it's just a good to know thing. In this procedure, he did a diagnostic bronchoscopy, but he's also saying he did a middle lobe bronchoalveolar lavage, right upper lobe bronchoalveolar lavage, and right lower lobe transbronchial biopsies. This is part of the diagnostic exam, so yada yada, you know, in case you want to go back and read it later. This is more of it. Spoiler alert, I read this before today's webinar, and I happen to know that more was done than just this diagnostic bronchoscopy, which is why nothing is highlighted on this page. On the next slide, we see where he actually gets into the meat of it. And he took the bronchoscope, wedged, remember that, what I said earlier about wedging, into the right middle lobe, and bronchoalveolar samples were obtained. So not necessarily a hard and fast rule with the wedging, but it kind of gives you some tips as you're looking at the documentation. This one, he gave us he flat out told us it's a bronchoalveolar lavage, but he also talked about wedging. He did the same procedure then in the right upper lobe, and then he went into the right lower lobe and took multiple transbronchial biopsies. This is going to be assigned 3 different codes. We had the bronchoalveolar lavage of the right middle and right upper lobe, and remember that because those are distinct body part values in PCS, we're going to code those out separately. And then that transbronchial biopsy, not only is it done on a different lobe than the bronchoalveolar lavage, it's a different root operation. And by applying our multiple procedure guidelines, we know that we have to assign yet a 3rd code for that. As far as sequencing on these, if you wanted to put your biopsy code first, you certainly can. These are not, the principal procedure guidelines are really going to consider all of these to be pretty much equal. Let's talk about lymph node biopsy. So transbronchial lymph node biopsy. Transbronchial means we're going through the bronchus. We are puncturing outside of the bronchi into adjacent lymph node tissue. And this is usually done with a needle. A lot of times they will use a fine needle. So it's a fine needle aspiration of the transbronchial lymph node, or the thoracic lymph nodes. And this slide just shows what the intent and the technique of that is. And the type of lymph nodes that can be sampled, you know, they can do paratracheal, mediastinal, or thoracic, but they're all going to code to the same body part, which is lymphatic thorax. It's pretty standard that this is going to be your body part for most of these. Your approach is via natural or artificial opening endoscopic, and right here is where I want to stop and throw out a huge caution sign. You need to be aware of outdated coding clinic advice. The body parts for lymph nodes were added to this table for fiscal year 2018, so brand new were we able to code this way, and their coding advice prior to that is invalid. And previous advice recommended different root operations and approaches. There was a time when we didn't even have an extraction table in this section because they hadn't taken into account being able to code this. And if you're wondering why this is coded as extraction, it's because they're putting a needle inside the lymph tissue and pulling back. That kind of sucks it out. It's not really cutting. It's suction, it's aspiration, and so it codes to the root operation extraction. Okay, Kathy, let's try this again with the polling question.
And I think you can hear me now because I think I identified what my problem was. So it was user error. So I am now launching the poll and you can actually hear me. So here's the question. Fine needle aspiration of the lymph nodes during bronchoscopy is reported with which root operation? Is it excision, extraction, or drainage? So I'll read it to you again. Fine needle aspiration of the lymph nodes during bronchoscopy is reported with which root operation? Is it excision, extraction, or drainage? And I do believe Christy was just talking about this on the previous slide. So I've got just a little over 50% of you have voted on this one. Anybody else want to weigh in? Yep, I'm moving up to almost 2/3 of our audience. I'd love to at least get 2/3 because then at least I'm getting the majority of the audience out there. And this always leads to great discussion. So on your screen, you should be seeing kind of our quick poll. There's the question, is it excision, extraction, or drainage? Okay, I'm closing the poll in 3, 2, 1. Okay, we do have a majority at 87% identifies this as extraction, but we have about 10% of you are saying it's drainage, and we've got a small percentage who are saying it's excision.
All right, thank you, Kathy. So this one is extraction. And if you are kind of old school, thinking back to before we had an extraction table, Back then, the advice was to code this as excision, but now that we have the extraction tables, that advice has changed. If you are focusing on that word aspiration and thinking fluid, remember that with a fine needle aspiration, we're sucking out tissue, not fluid. And that's what makes this an extraction over a drainage. So extraction is tissue, drainage would be our fluid if it was done. Okay, thank you, Miss Kathy. So let's move on to extirpation, that word that you'll probably never see documented in a report, but that's okay because we know what that is. And extirpation is removal of solid matter. In the respiratory system, in bronchoscopy, that's typically going to be either a mucus plug or a foreign body. And in the pictures we have here, this is removal of a foreign body. It looks like a kid who inhaled a button. At least I hope it was a kid. I hope an adult didn't inhale a button. And you can see that they put, through the scope, they put a balloon catheter down, inflate that past the area where the foreign body is, and then they're able to pull back and pull that foreign body out. Mucus plugs, I think, are a little less intuitive. And there is a coding clinic on this one regarding coding for removal of a mucus plug. And if you think of, mucus plug is not secretions, so it's not that more liquid material. This is really sticky, more like solid matter mucus that we see in some patients with some really nasty respiratory conditions, and we need to pull that out so that they can breathe better. The example that we have for this one is a patient with right lung atelectasis and extensive mucus plugging in the right main stem bronchus. They've got such a plug in the right bronchus that it has caused the right lung to collapse. So they go in. This one in the highlighted area says he removed thick, sticky, gray secretions filling the right main stem bronchus. Yuck. But definitely stuff you want to get out of there. This is going to code to the root operation extirpation, as I mentioned. The table is 0BC, and here's our final code here. It's extirpation of the right main bronchus, and again, the via natural or artificial opening endoscopic will always be our approach for our bronchoscopic procedures. Let's move on to dilation. The intent of this is pretty similar. We're trying to open the airway to improve airflow. And one of the examples, I actually did find an operative report for this, but I figured I had enough for a 1-hour presentation, so I just condensed it. The example here, direct laryngoscopy with rigid bronchoscopy and dilation of a subglottic upper tracheal stenosis. And that codes to dilation of the trachea. Again, root operation dilation, body part trachea, our approach always being 8 for the natural or artificial opening endoscopic, and no device because this was a balloon dilation. I think this was a balloon dilation, and nothing was left in place. When we look at the dilation table for this, table 0B7, we see several body parts. We see our approach here that we're going to be coding from, and we see a couple of devices. When we have intraluminal device, which is a stent, and then no device for like the case that we had on the previous slide. For tracheal and bronchial stenting, the intent is to place the stents in the trachea or the bronchus to open up the airway. And for those of you who are into cardiology or interventional radiology, the vascular stuff, it's the same concept. You can balloon it open, or you can balloon it open and then place a stent. And the inset picture here shows the catheter, the stent mounted on a balloon being placed into the airway and then expanded. And what we're left with here is lattice work. They look like, to me, they look like little rolls of chicken wire or chain link fence that get stuck inside the airway to help hold it open. This is different from an endobronchial valve placement, and this is quite a fascinating procedure. The indication for this procedure is usually emphysema, but also this can be done for people with air leaks. Before I get into how the procedure is done, let's talk a little bit about emphysema. This picture looks a little bit different than the one we saw before. Remember our nice, pretty grape-like alveoli? Well, this is a patient who has emphysema, and we have breakdown of the walls in the alveoli and increased expansion. And what happens in a patient with emphysema is as the alveoli become damaged, they inhale air but are unable to completely exhale what they have inhaled. And that causes further expansion in the alveoli. It's kind of like a balloon that you keep blowing up and you don't ever let any air out, and you just keep blowing it up and you never let any air out. Patients who have emphysema a lot of times have a barreled chest, where their chest cavity becomes bigger to accommodate the increasing size of the lungs and the alveoli. An endobronchial valve placement is a form of lung volume reduction therapy for patients who have emphysema, and this is a one-way valve that gets placed inside the bronchial, the offending bronchus, and the valves prevent air from getting to the damaged alveoli while allowing air and secretions to escape. So things can get out, but nothing can get in. So we're now at least preventing that balloon from inflating even more. This is a preferred method of treatment because it's reversible. And if you think of traditional lung volume reduction surgeries where it involves removing lobes of the lung, that's not something that's reversible. So in this one, they can go in and take this valve out in the future if they need to. And this can also be done for patients who have air leaks, and that would be for somebody who has an air leak distal to this valve. The endobronchial valve placement, when I think about it logically, I could think of a couple of different root operations that might work. But the root operation is insertion, and you'll know you're in the right table when you get to this device. And the device is specifically for an endobronchial valve. It's intraluminal device, endobronchial valve. And again, your approach is always going to be 8, and your body part could be any of the bronchi, any or multiple of the bronchi. A note about hemorrhage control, and this one kind of drives me crazy. I don't know if anybody else shares my disdain for the root operation control, because I find the guideline to be really convoluted. Remember, before I get into the guideline, I just want you all to remember that there are very few tables in the PCS codebook that have this root operation. Prior to the current fiscal year, it was only found in the 0W3 table, but for fiscal year 19, they added one in the nose body system somewhere so that we could code control of nasal hemorrhage. But there is no control body part in the respiratory body system. In order to code hemorrhage control done or performed through a bronchoscope, the table is 0W3 and the body part is respiratory tract. It's a very generic body part, and this goes to be a natural or artificial opening endoscopic. But remember, the control root operation is stopping or attempting to stop post-procedural or other acute bleeding. If you haven't looked at the guidelines in a few years, this has changed. It used to be reserved just for post-operative or post-procedural bleeding. Now it includes acute bleeding. And if that, but there's an addition. If an attempt to stop post-procedural bleeding or other acute bleeding is unsuccessful, and to stop the bleeding requires performing a more definitive root operation such as bypass, detachment, excision, extraction, reposition, replacement, or resection, then the more definitive root operation is coded instead of control. Okay, Kathy, that brings us to the last polling question of the day. Are you unmuted?
I am now unmuted. Okay, here's our question. What is the device value for the one-way flow device placed in bronchi to prevent distal alveolar expansion for emphysema? We have a lot of tongue twister words in this one. So your choices are interluminal device with endobronchial valve, or no device. So what is the device value for the one-way flow device placed in bronchi to prevent distal alveolar expansion for emphysema? Is it interluminal device? Is it interluminal device and endobronchial valve, or no device? And I see people are kind of thinking on this one. I've got a little bit more than 50% of you who have voted. Oops, we just took a big jump up. So I think here's your last chance. Anybody else want to weigh in? I'm going to close the poll in 3, 2, 1. Okay, Christy, we've got an overwhelming majority at 97% is saying it's interluminal device endobronchial valve, but we do have a couple people who are saying it's just interluminal device.
Okay. Boy, that was fun listening to her stumble over those words. I didn't write this question. I just want you to know I had help. You guys are right. 97% of you, it is interluminal device endobronchial valve. I had this worded differently, and one of my colleagues thought it was a little too simple, so we had to up the difficulty value both for you guys as well as for Kathy. But we apparently couldn't trick you because 97% of you got it correct. All right, Kathy, let's move on to kind of an ugly procedure. This is a multiple procedure case study. This is a patient who has airway stenosis with self-expanding metallic stent complication. And in this is several slides long. This patient ended up going a rigid bronchoscopy with removal of foreign body. I'll tell you ahead of time that that's the stent, the complicated stent. And then he talks about excision of a granulation tissue tumor. And I got to tell you, before we get too much further into this, not a huge fan of the documentation in this particular case. We have bronchial dilation with a balloon bronchoplasty. We have argon plasma coagulation to control bleeding in the trachea. We have placement of a tracheal and bilateral bronchial stents. The endoscopic findings here were important for what exactly that complication was, which of course is going to be important for the CM portion. This patient actually had multiple stent fractures in the mid portion of the trachea. And then he has high-grade obstruction of the right main bronchus by stent and granulation tissue. Granulation tissue is the body's natural response to a foreign body. And that stent, even though it's there for therapeutic reasons, is a foreign body, and the body's going to react to it. In this case, it has reacted by creating this excessive granulation tissue, which is obstructing the right main bronchus. That the patient also has left main bronchus covered by the distal portion of the stent that was only being ventilated through the struts of the stent. This is bad. This is a bad situation for the patient. In this procedure, he talks about dilating the right main bronchus, cauterizing it to control the bleeding, and then piecemeal remove the stent from distal to proximal. And in this procedure, we have elected not to code the control of the hemorrhage because it's going to be expected that if you had to do a dilation or remove some of this stent, that there's going to be some bleeding, and that's going to be considered integral to the procedure and not something we code separately. He did some other stuff, but then he gets down and he talks about placing the stents in the trachea, left and right main bronchus using a Dumont Y stent. And nowhere in here does it talk about removing this granulomatous tumor, I think is what he called it on the previous slide. And then the last of the report. And I was okay when I first read the report until I tried to code it, and then I kind of felt like the wolf here, like all the air had been let out. But what we ended up coming up with was, first of all, they placed a Y stent, and this is exactly what a Y stent looks like. It just happens to be an upside down Y. It's a one-piece stent. And I went back and forth with my team on this one, and we finally decided that, yeah, we should probably code the dilation of the bronchi separately because we're going to apply two different coding guidelines here. First of all, the multiple procedure coding guideline. When you have the same root operation performed on different body parts with different body part values, you assign a code for each. The big caveat here is that we have a different guideline. Remember, we talked about the inspection guideline earlier, but there's also another corresponding guideline that's very similar that says that if you do a procedure on a continuous section of a tubular body part, you only code to the most distal body part. So we went back and forth on this. Do we code the trachea? Do we not code the trachea? We elected not to by applying that guideline that talks about coding only to the most distal body part. But it happens that the most distal body part is a bilateral body part. But when you get into the tables, there is no bilateral body part value. So by applying the bilateral body part guideline, we end up with a code for dilation of the right main bronchus and a code for dilation of the left main bronchus. We're also going to assign a code for the intraluminal removal of the existing stent, the fractured stent. The codes that we elected to omit were the control of hemorrhage, because we considered that to be integral to the removal of the stent and everything else that was going on with this patient. And then we also elected to not code the removal of the granulomatous tumor, which he does not specifically address in the body of the report, but to which we think is just kind of cleaning up the area around the stent, where the stent was, and that would also be considered integral. So kind of an ugly procedure here. This is a first, Kathy. I have ended early today. So here is a list of the references that I used for today's presentation, and we have time today for questions. So Kathy, have we had any questions come in?
We do, Christy. We just had a couple questions come in, and so it's awesome that we've got some time to answer them. But I do want to encourage anybody else, if you have any questions, go ahead and type them in the chat window now, and we'll get through what we can, and what we don't, like I said, we will put together an FAQ video. So Christy, the first question is, what about EBUS, E-B-U-S? Should we be reporting an ultrasound code?
So that must be somebody who has coded these on the CPT side, because I know that there are specific codes for EBUS on the CPT side. It stands for endobronchial ultrasound, and a lot of times it's used for sampling lymph nodes during bronchoscopy. On the PCS side, there are no ultrasound codes in the lymphatic system, but there is a general mediastinal ultrasound code. So the use of this code is solely going to be at the discretion of your facility. You should have a facility-specific policy in place. Personally, I don't recommend coding it unless there's a specific need for that data by your hospital. I'm kind of putting on my coding manager hat here and thinking it's just kind of taking a productivity hit when we don't really need to. So I would only recommend coding that if there is a need for it from your facility.
Perfect. Thanks, Christy. And we've got another one. If dilation is performed in a bronchus and it was not effective, so they placed a stent, would you code dilation both with and without a device?
And this is similar to what we do on the cardiovascular side. So no, you would not code dilation with no device and then a separate code for dilation with a device. The intent of the procedure is to dilate, and so our root operation is going to be dilation, and you would code it as with the intraluminal device, which would be considered the most intensive piece of it, and then you'd be good.
Okay. What about control of hemostasis by embolization? Sorry, I'm trying to read the chat window. If they take the patient to the interventional radiology lab without trying other methods to control the bleeding first, what route operation should be used?
Wow, you really butchered that one. It's a good thing I can see what's in the chat window. The word is hemoptysis. So control of hemoptysis by embolization. You know, by the time they make a decision, the decision to take the patient to the interventional radiology lab, they've probably tried another method. To me, embolization is a really big deal. It involves taking them to the IR lab, advancing in catheters through the vascular system and controlling the bleeding from the source instead of doing it through a bronchoscope. In that situation, I would probably code it to occlusion using the interventional radiology procedure as opposed to control, because it just seems much more appropriate.
Well, thank you, Christy, for that one. I was afraid that I was kind of butchering how I was saying that, so I apologize. So we did have a couple more that have come in, so while we've got time permitting, let me go ahead and read the additional ones that have come in. So do we code bronchial wash and lavage on the same body part separately in CPT?
Oh, I'm afraid I'm going to have to refer you back to Shay's webinar that she did last week that addressed CPT. My CPT bronchoscopy knowledge is old, probably about 15 years old, and I would check that one out there, but I'll tell you what, I will forward this to Shay and the team so that we can get that answered for you.
Great. And like I said, we'll pull together all of these questions just because I know some people have had to jump off early. So we'll put together the FAQ video and make sure that everybody has that link as well. So we just have time for one more, Christy. Can you give another example of when we would apply PCS guideline B41C, and that is procedure performed on continuous section of a tubular body part? Code body part value to the furthest anatomical site. Looks like they are wanting another example of when you would apply that PCS guideline.
I'm trying to think of another example for bronchoscopy, and I really can't think of one. Anytime I think of this guideline, it is usually specifically to dilation. So I think about angioplasties and dilations and atherectomies in the vascular system. I think about dilations in bronchoscopy. You remember things like biopsy wouldn't apply here. So I'm sorry, I don't have a great answer for you, but I can't think of another example. It's not going to be something that you're going to see a whole lot.
Okay. Well, that brings us up right at the top of the hour. So I'll leave the chat window open for a couple more minutes if anybody else wants to ask Christy any more questions. And like I said, we'll compile all these. We'll put them into video format so that they all get answered. She will take them back to the team, and then we will make sure that you have the link. So look for the follow-up questions next week. So I want to thank everybody for your time this afternoon. We hope you enjoyed today's presentation. Be sure you check our website out for next month's presentation. And we want to thank you very much. And I want to thank Christy for an awesome job of presenting. So thank you. Have a great day, and we will see you next month. Bye-bye.